Okay, now we're going to talk about multiple endocrine neoplasias, men. One of the good mnemonic is men are dominant. Uh, so they're all of these men, 1, 2A, 2B, all of them are going to be autosomal dominant inheritance. Simple, right? But most importantly, we got to know which men includes what. For that, we have a very nice picture here. Okay, so let's take a look at this first, and then we will read what the book has to say. So first thing we have is men 1. It has 3 P's. In those 3 P's, we're getting something from top, which is pituitary, 1 from pancreas, and 1 is parathyroid, right? 70%. Now, importantly, in men 1, 90% of the patients will for surely have this parathyroid adenoma or hyperplasia, 90%. And pituitary adenoma is about 70%, all right, of these men 1 patients specifically. Now, if you look at men 2, it has 2 P's and 1 M. So just remember, men 2A does not have any physical findings, no physical findings, and that's going to come high yield when we talk about men 2B. Okay, men 2A, no physical findings. 2B, yes, physical findings are there. Okay, so men 2A, what do we have? We have 2 P's now: parathyroid, pheochromocytomas, and medullary thyroid carcinoma. Now, importantly, now which ones occur first here? So high yield point is going to be your medullary thyroid carcinoma occurs first, and then you have pheochromocytoma, which is the adrenal medulla tumor, right? So, and now when I talked about no physical findings, you got to know it because when you compare with men 2B, all men 2B has is it's going to be 1 P's and 2 M's, and that 1 P is your pheochromocytoma, and 2 M's are your, again, medullary thyroid carcinoma and mucosal neuromas. Now, high yield for this guy, for men 2B, is going to be for your physical findings that in these patients, they have, first of all, look at this picture of mucosal neuromas here also, mucosal neuromas. Now, on top of mucosal neuromas, they're also going to have another M called marfanoid habitus. Okay, they will have marfanoid appearance, and we will talk about it when we go into details, which is also mentioned with it here. But what I want you to know here is simple thing, and we will talk about the whole thing, and there's a good mnemonic. Actually, let's talk about the mnemonic first here. Okay, all we want to do is, okay, we have men 1, right? Men 1, you are going to think about 3 P's. 3 P's. Those 3 P's are going to be, first of all, from top, you got the pituitary, and then you have the pancreas. These are 2 P's, right? Third P, you're just going to put in the middle like this, parathyroid. And with men 2, you are going to think of 2 things. Men 2, both of them will have specifically both of these 2 things, which are your, again, the pheochromocytoma. I'm just going to write pheo, and medullary carcinoma of thyroid. Okay, these 2, men 2, no matter A, B, both have these 2, right? Now with an A, because you just go up top, which was the parathyroid, you just include that one with A. With the B, you include those physical findings that we talked about. Physical findings, for example, let's just put them here as well. We have mucosal neuromas, and the marfanoid habitus. Okay, so this is going to be pretty much what we have for this, and let's just read it and then move on. This is what you got to know this. It looks simple, but if you know it, it's worth it. Okay, with that, let's move on and let's read this now. Okay, men 1. Men 1, we talked about it. We have a pituitary tumor. Pituitary tumor most commonly secretes prolactin or growth hormone that you know already. Now, the pancreatic endocrine tumors could also be the pancreatic endocrine ZE syndrome, Zollinger-Ellison syndrome, insulinomas, lipomas, gluconomas are rare. Anything. When you talk about pancreatic endocrine tumor, any endocrine part of the pancreas can go into tumor. Parathyroid adenoma, not only adenoma, but you will see it will be seen as hyperplasia of the parathyroid gland. Okay, that's also seen. And how is this going to present? Again, it's going to present with increased calcium. Simple. They might not even mention all of this, the parathyroid adenoma, hyperplasia, but they will mention with association with increase in calcium, and that will cause recurrent kidney stones. Kidney stones. A patient coming in with recurrent kidney stone and has some sort of other thing, you are going to think about parathyroid adenoma associated with men 1. Okay, with that, you have to know, okay, there is a mutation in men 1. What is men 1 anyways? That's the tumor suppressor, which codes for menin, right? Which is chromosome 11. 1 is 11, but not high yield. Just to know, okay, men 1, menin, chromosome 11. Other than that, you can have angio associated with angiofibromas, cholangiomas, and meningiomas, not high yield. Move on to M2A. 2A, these are all going to be your medullary tumors, right? Medullary tumors, in which, if you think about it, parathyroid is also parathyroid hyperplasia, medullary, and adrenal medulla, right? Which is pheochromocytoma. So 2 medullary and 1 parathyroid hyperplasia. With that, let's talk about each one of this. You have medullary thyroid carcinoma, which is a neoplasm of a parafollicular C cells. They won't mention this, right? Well, what are they going to mention? Hypocalcemia. If they're mentioning this parathyroid with hypercalcemia, so they will mention medullary thyroid carcinoma, which is a parafollicular C cells, which secrete calcitonin. So they will mention this with low calcium. So low hypocalcemia. So low calcium. Okay. Okay, now importantly, most importantly, that you have this, right? You have this is a neoplasm parafollicular C cell which secretes calcitonin, so prophylactic thyroidectomy is required in patients with MEN2A. So and let me write it. I don't know where it is in the book, but if you see a patient with a RET mutation, prophylactic thyroidectomy is required, because eventually they will go into medullary thyroid carcinoma. So before, I guess they mentioned it here, before they even go in there, you just got to remove the thyroid. Simple. Okay. And then you have pheochromocytoma, which secretes catecholamines, right? And a mutation. MEN2 has a mutation in RET, same as MEN2A, B have RET. So why don't we say it this way? MEN1 is going to be mutation in MEN1, same. MEN2 mutation in RET. So all you got to remember in the whole page is RET, because other than MEN1 is MEN1 right there, right? Is only one difference is RET, which is here. Simple. Okay, just remember RET, autosomal dominant RET for 2, because both are 2. Now what we want to know, what is RET now? We got to understand what is RET. Okay, for RET, let's read first here. Mutation in RET. RET is a proto-oncogene which codes for receptor tyrosine kinase on chromosome 10. Okay, so when you have a pro-oncogene which codes for receptor, and you have a mutation here, and this mutation is a gain of function mutation. That's very high yield. It's a gain because you will see other red mutations which are not gain of function, but here specifically we're talking about gain of function, meaning you have increased red, meaning increased tyrosine kinase. When you have increased tyrosine kinase, guess what's going to happen? Well, you are going into unregulated growth and differentiation. That is why you are going to develop all these medullary carcinomas. Okay. Then you have, what else you can have in this? Okay, let's go on to the last one here, and that is our MEN2B. MEN2B, medullary thyroid carcinoma, which is from top. So I'm just going to do the same color here. Pheochromocytoma from top. The only new thing here is going to be your physical findings. Mucosal neuromas. Look at picture A. What are these neuromas? Well, these are oral or intestinal ganglioneuromatosis. Okay. These are benign growth. What are they basically? They are benign. First of all, they're benign growths of nerve tissue. Okay, so they are benign growths of nerve tissue. Simple. So all these are that you see as a protrusion on the tongue. Let me see this diagram. Look at this one. So these are just nerve tissues. They are just nerve tissues, and they look fleshy. So let's just define this. They're gonna on the description they will say, okay, this flesh-colored nodules. So let's just write it: flesh-colored nodules anywhere along oral and intestinal area. Okay, so let's just put it on lips or on tongue or anywhere in GI. Flesh-colored nodules. Okay, important. And then you have, so you got mucosal neuromas. The next thing we have with MEN2 is going to be another physical finding. That's your marfanoid habitus. Marfanoid habitus. Now, we have to differentiate marfanoid habitus because when you see marfanoid habitus, you might think of Marfan syndrome, right? Marfans. So how do we differentiate? So let's talk about marfanoid habitus. Marfanoid habitus, you will have a tall, disappropriate arms, 2 legs ratio, joint laxity, right? But all of this is going to be present without, which you will just see with Marfan, without ectopia lentis, or aortic involvement. So in Marfan, let's just put it this way. With Marfan, you will see all of this. On top of it, you will see ectopia lentis and aortic involvement. But with marfanoid habitus, which is not Marfan syndrome, all you are seeing is the tall with an disproportionate arms to legs ratio, joint laxity, and all the other findings of just the habitus, not the Marfan syndrome. Okay, hope that makes sense. And that is going to be all. Let's just review the whole part and move on. So here we have the first thing. Men are dominant, autosomal dominant disease. MEN1 mutation, MEN2 ret mutation. No matter 2A, no matter 2B, both are ret mutation. MEN2A, all are medullary. Let's put it this way. Let's put it easy way. MEN2, no matter you are looking at A or B, all are medullary. So the common feature that they have together as MEN2, meaning 2 medullary tumors. 2 for 2, right? What are they? There are going to be medullary thyroid carcinoma and adrenal medulla, which is pheochromocytoma, right? Both of them have that. Now, with an A, you're just looking at the parathyroid coming from top. B, all you're looking at the B physical symptoms. B means two physical symptoms are going to be mucosal neuromas and morphoid habitus. And that is going to be all. Let's move on to the next part. Here we have pancreatic islet cell tumor. And these are going to be your insulinoma. Insulinoma is a tumor of pancreatic beta cell, which leads to overproduction of insulin, which leads to hypoglycemia, right? May see Whipple triad, which is high yield. What is a Whipple triad? Low blood glucose, plus you have symptoms of hypoglycemia, which are lethargy, syncope, diplopia, and resolution of symptoms after normalization of plasma glucose levels. Three things. That's why called triad. Symptomatic patients have decreased blood glucose and increase in C peptide levels. Got to know this. You would have increase in C peptide versus exogenous glucose. Remember, insulin comes along. When insulin gets out of the pancreatic beta cells, it comes as insulin plus C peptide. But if you're giving someone from outside, exogenously you're giving insulin, you're not giving C peptide with it, right? You're just giving insulin. So C peptide will not be raised. But if it is endogenously insulin is coming out, it's going to come out as two parts, insulin plus C peptide. And in fact, the C peptide has a longer half-life. And that is why we check the C peptide levels if we are thinking about insulinoma or anything else to see how the endogenous production of insulin is working. Okay, so increase in C peptide, 10% of the cases associated with MEN1. And we did talk about how insulilomas or any of these diseases, pancreatic endocrine tumors, insulinoma right here, right? Any of them, ZE syndrome, lipoma, glucagonoma, anything. You think about MEN1. All right. So here's the same thing. MEN1. It is associated. 10% of the cases are associated with MEN1. Treatment is surgical resection. Okay, let's review this and move on to the insulinoma. Just think about Whipple triad, low blood glucose levels and their symptoms and resolution after you have normalized the glucose level. Although look at the name, Whipple triad. No, but if you don't know Whipple triad, the word is so diffusing. Like you think Whipple, what is gonna be? It's simple. Got to just remember Whipple, low glucose. Symptoms of low glucose. You give the glucose, you're good to go. The symptoms resolve. The Whipple triad, simple. Okay, with that, moving on to the next one. Now we got the glucagonoma. Glucagonoma is a tumor of the pancreatic alpha cells because alpha cells secrete glucagon and beta cells secrete insulin. So that's pretty well understood. Then you have the overproduction of glucagon, right? Glucagonoma produces glucagon, simple. Presents with 6Ds, high yield, 6Ds, dermatitis, which is necrolytic migratory erythema, diabetes, hyperglycemia. Okay. And again, why is it causing, now you ask, hey, why glucagon is causing diabetes? Because if you remember, glucagon is one of the counter-regulatory hormones. All the counter-regulatory hormone, all of their job is to put glucose back into the serum, right? When they put the glucose in the serum, you're causing hyperglycemia. What is hyperglycemia? Isn't it diabetes? It is. Okay. And that's why it's mentioned here. It also leads to DVT, declining weight, depression, diarrhea. Okay. Let's talk about a little bit about dermatitis with the glucagonoma. glucagonoma, you had dermatitis, which is necrolytic migratory erythema. This is going to be seen as blistering erythematous plaques with central clearing. Okay, so let's just have a central clearing, but it's going to be blistering erythematous plaques. Erythematous plaques. Okay, with that, where are they going to mention this? So let's actually dive a little deep into dermatitis here. Dermatitis with the increased glucagon is going to be, first of all, as they mentioned, necrolytic migratory erythema. Erythematous plaques or papules will be present on where? Will come on face, extremities, or the perineum groin area. Okay, lesions will enlarge. So these lesions will enlarge and coalesce, leaving a central innervated, like a depressed area with peripheral blistering and scaling. And this whole thing, dermatitis, the same sort of dermatitis, if you go back in your book, you will see zinc deficiency. It is also seen with zinc deficiency. It's going to be in your biochem section. But for sure, with zinc, you are going to have the zinc problems, zinc findings. Okay. But this is important of dermatitis, glucagonoma, dermatitis. The mind doesn't go there, but you got to push the mind. Okay, glucagonoma, something important. Dermatitis, diabetes for sure, DVT, declining weight because you are trying to put everything in. You are trying to increase lipolysis, increase proteolysis. You are trying to put the whole thing into the bloodstream. For sure, you're going to go into weight loss, declining weight there, depression, diarrhea. Okay. And that is going to be pretty much all. One important thing is if you were to decrease, so this is glucagonoma where you're increasing glucagon, right? Just another story. If you have low glucagon, which is not this one, but if you have low glucagon, one of the things that you have to know that with low glucagon, you are going to go into hypoglycemia. Okay. So let's review it quickly. We have glucagonoma, meaning overproduction of glucagon, 60s, dermatitis, high yield, diabetes, DVT, declining weight, depression, diarrhea. Treatment is octreotide surgical resection. But in the opposite case, if you have low glucagon, you're not going into hyperglycemia, but you are going to go into hypoglycemia. So with higher glucagon, hyper; with low glucagon, hypoglycemia. With that, let's move on to the next part, which is somatostatinoma. Okay, somatostatinoma, which is a tumor of pancreatic gamma cells. Overproduction of my bad, delta. Okay. Tumor of pancreatic delta cells, which is the overproduction of somatostatin, which leads to decreased secretion of secretin, CCK, which is cholecystokinin, glucagon, insulin, gastrin, gastric inhibitory peptide GIP. So all you gotta, I mean, who's gonna remember all of this, right? I don't think. Well, if you can remember, great. You're great. You're genius. But simple way that you can understand this is, okay, somatostatin is the blanket of all hormones. Blanket of all hormones. So when it is blanket of all hormones, no matter what hormone you have, you think about secretin is gone, CCK gone, glucagon gone, insulin gone, GIP gone, everything is just out because it's a blanket. So somatostatin, statin means inhibition of all hormones here, okay, may present with diabetes, right? Glucose intolerance, because you are inhibiting insulin here. So diabetes, glucose intolerance, steatorrhea, gallstones, and achlorhydria. Okay. Treatment is going to be surgical resection, or you can give somatostatin analog, for example, Octreotide, for symptomatic control. Okay. So that is going to be all for this stomatostatinoma. Okay. Then you have, so let's just review it first. Somatostatinoma, simple overproduction of somatostatin, which is a blanket of all GI hormones, is going to inhibit all GI hormones secretin, CCK, glucagon, insulin, and GIP. It can present with glucose intolerance, diabetes, steatorrhea, gallstones, achlorhydria. Treatment is going to be, you have to either surgically resect it or give an analog from outside, which is Octreotide, for symptomatic control. Moving on with the next thing is going to be the carcinoid tumor. Carcinoid tumor arise from neuroendocrine cells. Yeild, they arise from neuroendocrine cells, most commonly in the intestine or lungs. Neuroendocrine cell, they secrete 5-HT, which is serotonin, which undergoes hepatic first-pass metabolism and enzyme breakdown by MAO in the lungs. Okay, so if it is going into extensive first-pass metabolism, this serotonin, if it goes to the liver, it's going to get destroyed by all MAOs, right? And if serotonin reaches the systemic circulation after liver metastasis, carcinoid tumor may present with carcinoid syndrome, which is episodic flushing, diarrhea, wheezing, right-sided valvular heart disease, which is tricuspid regurg, pulmonary stenosis, and increased urinary 5-HIAA. Excess 5-HT production depletes tryptophan stores, leading to niacin deficiency, which is pellagra. Okay, with all of this, let's take a look at now. I guess we have to go back to the biochem. So what is biochem for all of this tryptophan and all that? So if you know you have a serotonin metabolism, how is serotonin metabolized? First of all, you have tryptophan. Synthesis of serotonin is like this. You have tryptophan, and then that tryptophan becomes your 5-HTP, which is your 5-hydroxytryptophan. Simple. 5-hydroxytryptophan by the enzyme, which is sort of I don't know if it's a low yield, high yield, but biochem just know the enzymes. Okay. Tryptophan hydroxylase. Okay. 5-HTP, which is 5-hydroxytryptophan, forms 5-HT, which is tryptophan, which is serotonin, my bad, right? And this serotonin then gets into metabolism by an enzyme, which is MAO. MAO is only present here in the liver plus lungs. Okay. And when you metabolize your serotonin, what are you forming? You are going to form 5-HIAA. Well, actually, the first thing you're going to form is 5-hydroxy indole acetyl dehydrogenase. And then that leads to, when the aldehyde dehydrogenase exon, it is going to form 5-hydroxyinidole acetic acid. So what is it? 5-HIAA, hydroxyinidole acetic acid. This, now, if you have a lot of, so let's, now with all this in background, let's take a look here now. We have increase with carcinoid tumor, which essentially is a neuroendocrine tumor, which is secreting a lot of serotonin, that a lot of serotonin will get degraded, right? And when you degrade serotonin, you're going to get a lot of metabolite in the urine, and because it's making a lot of serotonin, you're going to deplete its precursor, which is tryptophan right here. So it's going to decrease tryptophan. When you decrease tryptophan is also necessary for niacin, so it's going to cause niacin deficiency, pellagra. Okay. With that, now let's look at the histology. Histology, we have rosettes. Picture A, you can see some rosettes. Chromogranin A and synaptophysin A, synaptophysin positive. So what are these rosettes? Let's talk about these first. Histology. So these are, I don't know if you can see in the picture, but they are properly arranged cells in a circular manner. So they are the islands, sheets of cells, of uniform small cells, eosinophilic, which means pink. They're pink, right? So eosinophilic cytoplasm, oval to round nuclei with peripheral palisading. High yield, these nuclei will look like salt and pepper chromatin. Okay. It's like salt, and within the nuclei, you will have some granules, salt like salt and pepper chromatin. Okay. But what do we need to know? These are going to be rosettes. They're going to look like rosettes, which are just uniform peripheral palisading cells with pink cells, eosinophilic cells. Okay, with that, let's look at the diagnosis. How do you diagnose it? Again, you got to look at 24 hours urine excretion of your 5-HAA, which is your metabolite of the serotonin. Okay, Octreotide scintigraphy will lead to tumor localization and staging. Okay, then you have the treatment. For the treatment purposes, you have surgical resection, somatostatin analog. Again, the reason behind we giving somatostatin analog, as we said, somatostatin inhibits all hormones. So if you give somatostatin, it might inhibit it. Octreotide or tryptophan hydroxylase inhibitors, or you give tryptophan hydroxylase, this first enzyme. You want to inhibit this enzyme so you don't even make serotonin, okay, which is tryptophan hydroxylase inhibitors. Example, the drug is telotrestat, okay, for symptomatic control. Because if you inhibit this, you're not making serotonin, you don't have symptoms of serotonin because you're not making it. Okay, there are rule of thirds. What are rule of thirds? Let's change color here. 1/3 would metastasize, 1/3 would present with secondary malignancy, and 1/3 are multiple. Okay. With that, let's talk about little extra things, which we did mention in the first place here. Okay, so now we got the whole idea about carcinoid making serotonin. Now let's talk about where they are going to be present, right? So most commonly, they said here, they're most common present in either the intestine, which is your GI, or they're going to be in lungs, right? So if the carcinoma, let's talk about GI and lungs. So let's just zoom in here. I actually don't have space, so let's just talk it here. Okay. So if you're talking about a GI, for example, carcinoid tumor in GI, most common location is going to be within the GI. The most common location is the ileal tumor. Okay. So in the ileum, we have this carcinoid tumor, most common. So from the ileum, it's going to secrete, so let's say this is GI. From the ileum, it's going to secrete the 5-HT, which is serotonin. That 5-HT will go to the liver, right? It's going to through all the portal circulation is going to go where? To the, well, I think this is very macro. I gotta write in a smaller way so we can make sense. So from here, the blood, it's going to go to the liver. Let's just draw liver here. Okay. In the liver, from portal circulation is going to go to liver, but in liver we have an enzyme. So in liver it gets metabolized by the enzyme MAOs, right? MAO. They're like, yeah, we got you, man. We're going to stop you right here. No more symptoms. So all you're getting is metabolism of your 5-HT into 5-HIAAs, right? So you have, important point is, so you're not going to see no or not much sign symptoms because it didn't even go outside. It wasn't blood. Didn't cause any problem there, right? That's one thing. Now the problem arises when the tumor from the GI, carcinoid tumor from the GI, send metastasis to the liver. Now this carcinoid tumor, which was present in the GI, now has the mets within the liver. And now what they're going to do within the liver, they're going to send out into the blood serotonin. And now when they send out into the blood the serotonin from the blood, the serotonin, okay, if you recall the blood supply from the liver, you're going into hepatic vein, and from hepatic vein, you are going to go into couple things. First of all, you have to go into IVC, and from IVC or hepatic veins, you are also going to send these the serotonin within the systemic into other smaller arteries due to systemic shunts. Then it's going to give you symptoms, and also from IVC, inferior vena cava, it is going into carcinoma. It's going to go into the right heart, and then the lungs. Right heart, there is something called carcinoid right heart disease, and I will talk about when it goes into the right heart, it's going to cause carcinoid right heart disease, and I will talk about that one. But when it goes to the lungs now, fortunately, in lungs, let's just draw lungs here. In lungs, what we have, this is more like kidney. I'm bad at drawing, but something like this. Okay, in lungs, we have, again, our good friend, MAOs. And when the serotonin reaches, so let me just put serotonin here, 5-HT, reaches lungs, it is then converted by MAOs into an inactive metabolite, which is 5-HIAA within the lungs. Okay. So, and then this goes into the urine, and we see 5-HIAA in the urine, we say, okay, we have a problem of serotonin metabolism. Now let's go back and understand the whole thing that I am trying to tell you. We said the most common location is in the GI or in the lungs. So if now, think about it. If you have a problem here in the GI, which is most common in the ileum, it could be in the appendix, it could be in the rectum. All three. In the intestine, what are we thinking about? What intestinal areas are we looking at? Ileal is the most common. Again, ileum, most common. Appendix could be one of it. If we are going, I don't know if you know appendix. Appendix is one of the things in appendix is these carcinoid cells being there. Appendix. Okay. The third thing is going to be your rectum. But all of them, what they are going to do, let's just get this into, is this? Yeah. Okay. So we have it in the GI. From the GI, when it sends you the portal circulation into the liver, now in the liver fortunately, we have these MAOs. These MAOs are going to destroy that serotonin. So we are not going to see any symptoms when we are talking about specific GI GI carcinoid tumor, no symptoms. But if again we have a GI tumor that goes and send the mets to the liver, now the tumor is in the liver now because the mets are here in the liver. Now they are going to send that serotonin outside into the hepatic vein and do IVC, and they're going to cause sinus symptoms. What are sinus symptoms? For example, they are going to cause flushing, another carcinoid symptom, which we'll talk about in a bit. But sinus symptoms are there, okay? And they're not going to stop there. They go from here. They also cause right heart carcinoid, carcinoid right heart, carcinoid. Where is it? Carcinoid, yeah, right here. Carcinoid right heart disease. Okay, from IVC, and then when it goes eventually into the lungs, then it gets destroyed and nothing goes out. But here now, what is the summary here? Summary is that if you have a problem in GI, specific only GI, not Mets, then you don't have any signs and symptoms. But if you have the Mets to the liver, basically the primary side is still GI, but the Mets are there, then you will see signs and symptoms. And you will also see signs and symptoms when you are talking about specifically lungs. Lungs, no matter what, because you have the symptoms of it over there, okay? Now let's talk about symptoms. Here are the symptoms. Carcinoid syndrome. So first, I guess with that, let's just quickly read this so you understand what I just talked about. So serotonin, which undergoes hepatic first pass metabolism, essentially saying, you as soon as you come from GI, you're going to go into first pass metabolism, which is through liver. From GI, goes to liver, gets destroyed. And enzyme breakdown by the MAOs in the lungs as well. Then you have serotonin reaches systemic circulation, that is going to give the signs and symptoms, right? What are they? After liver metastasis or carcinoid tumor may be present with carcinoid syndrome, which is symptoms are episodic flushing, diarrhea, important episodic flushing, diarrhea, wheezing, heart is also there, right-sided valvular heart disease, which is your tricuspid regurg, pulmonic stenosis. Again, on the right side, you have only two valves. You have the tricuspid, and tricuspid regurg is going to be there. But again, you can also cause pulmonic stenosis. So one is regurg, one is stenosis. With that, let's actually take a look at right heart here. Right heart, carcinoid heart disease is going to, and let's zoom in. Carcinoid heart disease is the right heart valvular fibrosis, right heart valve fibrosis. And why is fibrosis with the carcinoid? One thing that you got to know is a simple physiological factor. Okay, this is good. Okay. Simple physiological factor of serotonin. Serotonin is that serotonin stimulates a couple things. It stimulates fibroblast growth factors. Fibroblast growth factor, one thing. Second thing, it stimulates its fibrinogenesis. Fibrinogenesis. With that, let's take a look at now when it goes to the heart. When it goes to the right side of the heart, because it can go to the left because the lungs will metabolize it, so it only can affect the right side. Okay, so when it goes to the right side of the heart, it's going to cause valve fibrosis. Why? Because due to increase in collagen. By increasing collagen, and this causes two things. When you increase the collagen, causing fibrosis, it's going to cause tricuspid valve regurg and pulmonic valve stenosis. Okay, and the second thing which they haven't mentioned is it is also going to cause endocardial thickening. So just remember, the whole right side is just going to be thickened. When you thicken the tricuspid valve, you're going to go into regurgitation. When you thicken the pulmonic valve, you're going to go into stenosis. think about this as a hallmark, which is fibrosis by increasing collagen due to the fact that you have a lot of serotonin, which is the normal job of serotonin is the fibroelastin, causing increase in collagen. Okay. Let's talk about some more symptoms here. Some more symptoms. Well, let me erase these first. Some more symptoms and that you will see are going to be in your skin. You're going to have telangiectasias, skin, telangiectasias, cyanosis in skin, wheezing. Why is it wheezing there? Because serotonin causes bronchospasm, bronchoconstriction causing bronchospasm leading to wheezing. Okay. Watery diarrhea, cramping, recurrent diarrhea or watery diarrhea. Where is diarrhea here? Diarrhea. Which side of diarrhea are we looking for? It's going to be cramping, watery diarrhea. Again, you have increased serotonin. That's why. Okay. Again, on the right side, right heart side, you will see fibrous plaques, even fibrosis, fibrous plaques. Okay, with that, I think pretty much we did talk about most of the things. Yeah. Okay, now let's look at these are all the symptoms of carcinoid syndrome, which is essentially increase in serotonin. Now, one thing for going to be for the diagnosing, you have high yield is this again increase in 5-HIAA. It is used for screening purposes. So this guy 5-HIAA is for screening purposes. Now, to diagnose it, you have to go for CT scan or MRI. Wherever the locations are, where do you think it's going to be in? It's going to be in either the abdomen or it could be in the rectum as well. So just to abdomen, pelvis, to localize tumor. We are doing CT MRI to localize tumor to a specific organ. And highest yield is going to be your where are the markers here? Neuroendocrine markers, chromogranin A, synaptophysin positive. Okay, with that, I think we did a pretty good job here. Explained the whole thing. Okay, nice. So what we are going to do is quickly look at it and move on to next. Serotonin, carcinoid syndrome. Just think about carcinoid as increased serotonin. It can go into intestine or lung. Intestine means GI. GI means the most common ileum. Then you have appendix and rectum as other causes. But if it is in GI specific, it is within GI, it's not going to cause signs and symptoms. But if it sends the mess to the liver, it's going to cause signs and symptoms because from the liver, it's just going to go out. And liver will destroy it by MAOs or their first-pass metabolism. And the lungs will also destroy it by their MAOs. The symptoms are high yield, episodic flushing, diarrhea, watery diarrhea, recurrent watery diarrhea, patient, wheezing, bronchospasm, right heart valvular disease due to fibrosis, causes TR, pulmonic stenosis, high yield increase in 5-HIAA in the urine, and you have excess production, which will deplete tryptophan, leading to niacin deficiency, chromogranin A positive, synaptophysin positive, and you can resect it. You can give analog like Octreotide, or you can give the tryptophan hydroxylase inhibitor, which would inhibit its formation, serotonin formation or synthesis. With that, pretty much we are good. 1/3 would metastasize, 1/3 would present with secondary, and 1/3 are multiple. All right, that is all. Let's move on to the next part. Here we have Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is the constellation of symptoms resulting in acid hypersecretion from the gastrin secreting tumor. Again, as they mentioned, gastrin, so just remember The Zollinger-Ellison syndrome is, in fact, hypersecretion, acid hypersecretion from gastrin secreting tumor, gastrinomas in duodenum, most common, or the pancreas. So two areas, either could be duodenum, either could be pancreas. Okay, and then it leads to single or multiple recurrent ulcers in the high yield. Okay, if you have anything beyond duodenal bulb, if you have single or multiple, any ulcer beyond duodenal bulb, in the duodenum, most commonly they will say duodenum, okay, or jejunum, then you have often refractory to the proton pump inhibitors. You think about ZES now, okay, that's very high yield, with resulting malabsorption because of acid inactivation of the pancreatic enzyme secreted into the small bowel. Now this guy is going to present with abdominal pain, heartburn, diarrhea, steatorrhea, weight loss. Positive secreting stimulation test, which increases gastrin levels after secretin administration, which normally inhibits gastrin release. So normally secretin would inhibit gastrin release, but here in Zollinger-Ellison syndrome, where basically you have a lot of, what is Zollinger-Ellison syndrome again? It's just with the names, just always, go with what's the basic thing here. The basic thing again here, you have increased gastrin. Simple. Increase gastrin, or you can say gastrinoma, because everything was noma, right? Like, so gastrinoma, meaning increased gastrin. When you have increased gastrin, there's something secretin which normally would inhibit the gastrin level, but now when you give secretin, there's increase in gastrin levels. Wow. And that is just going to be a positive, that's called positive secretin test. Okay, then you have this chromogranin A positive, okay, maybe associated with MEN1. We talked about MEN1 being associated with all of these pancreatic endocrine tumors. Okay. With this, let's talk about a little bit about pathophysiology behind this gastrin. So when you think about gastrin, so let's just put it here. Gastrin, so normally gastrin causes what? Gastrin goes to the parietal cells, right? And that parietal cells leads to secretion of your HCl, right? So now think about it. When you have a lot of gastrin, you are, first of all, that a lot of gastrin is going to go to your parietal cells, is going to put a lot of acid, and that is the reason that you will have ulcers beyond the duodenal bulb or in the jejunum, right? And it's going to be refractory to PPIs because it's here you have a problem with, you have increase in gastrin due to a tumor, nothing else. So you can't stop a tumor by a drug, so you can't. It's refractory. That high HCl is going to be refractory to PPIs, and because you're putting in a lot of that HCl, hydrochloric acid, it's going to result in malabsorption because this acid would inactivate the pancreatic enzymes, high yield. This acid inhibits pancreatic enzymes, one thing, right? So with this acid is going to, first of all, it's going to stay within the stomach and it's going to go down. Wherever it's going to go down, you have ulceration of that. You're inhibiting the pancreatic enzymes. Third thing, it can cause heartburns. A lot of acid heartburns is going to be there, right? With diarrhea, steatorrhea, when you don't have pancreatic enzymes, you can't reabsorb your fat. So all those fats are going to go out, and you are going to have steatorrhea. Okay, weight loss is also there because you're not absorbing things, and that is why you have weight loss. But that's not important here. What is important is going to be your malabsorption due to pancreatic enzyme inhibition, steatorrhea with recurrent ulcer, which is the highest yield beyond the duodenum or jejunum. And that is going to be what we have. And you can test this out by giving a secretin stimulation test. Okay. One thing they will mention is when they do endoscopy, you will see enlargement of the gastric enlargement or hyperplasia of these parietal cells. So endoscopy will show hyperplasia of parietal cells in the stomach. Now, why is that? Because again, you go back, you have increased gastrin that is stimulating your parietal cell, which is secreting HCl. So you are stimulating your parietal cells so much that they are going into hyperplasia, and you will see that on endoscopy. Okay, simple as that. Moving on. Okay, let's just quickly review this. ZES, think about gastrin, secreting tumor, gastrinoma. Okay, in duodenum is most common. So location-wise, duodenum is most common site, or even the pancreas. It's going to cause ulcer beyond duodenal bulb or jejunum, which normally there's no ulcer in jejunum. By the time it goes in jejunum or duodenum, there is no acid. Okay, but here, because you're producing acid so much that it's just going to travel down and down, duodenum and jejunum. Okay, would resulting in malabsorption because that acid will inhibit pancreatic enzymes. You need that for fat absorption, so steatorrhea, diarrhea. Okay, with that because a lot of acid is there, heartburn, abdominal pain. Secreting stimulation test would normally inhibit these gastrin levels, but now this is a tumor, so it's not going to inhibit it. So that's why you can have increase in gastrin levels. It is associated with MEN1. With that, let's move on to the next. Okay, great. Pharmacology. Okay, the first thing we are going to talk about is called diabetes mellitus therapy, high yield. So what do we have here? So let's read first. All patients with diabetes should receive education on diet. So first thing, diet. Second thing, exercise. Third thing is blood glucose monitoring and complication management. Okay, treatment differs based on type of diabetes and glycemic control, for sure. So we have type 1 diabetes. For them, we need insulin. For type 2 diabetes, we need oral agents like Metformin, which is the first line of drug, or non-insulin injectables, or insulin replacement could be there. Weight loss, particularly helpful in lowering blood glucose levels. The third sort of diabetes is gestational diabetes, which is you can give insulin replacement if nutritional therapy and exercise alone fails. Okay. With that, let's take a look at some insulins. You have a regular insulin, which is a short-acting, is preferred for DKA, YIV, high yield. For DKA, we give IV because why we give IV a regular short-acting insulin? That it has a rapid action, and we will talk about that. But here, rapid action, and through rapid action, we can have DKA, in which we have more than 300 glucose. We can get that fixed. In DKA, if you recall, we have absolute insulin deficiency. So we need insulin from outside. That's why we give IV, that it goes right away and causes this action. We don't have to wait 30 minutes or 20 minutes for it to start working. We give IV. But in all the other ways, for example, this regular is so short-acting that it is normally given as a pre-meal insulin. Wait, here. So normally, regular, which is a short-acting insulin, is given as a pre-meal, meaning before you have a meal, you inject the insulin like 30 minutes before. Okay, but that pre-meal is given subcutaneous, and that is why you have a 30 minutes of break time. Okay, show time starts when? After 30 minutes. But we don't need a short time when we are going in DK, do we? We want right away, stat, IV, get right away, start work right away. That's what we're getting paid for. But okay, moving on with hyperkalemia. With glucose to prevent concomitant hypoglycemia and stress hyperglycemia. Okay, so again, what did we talk about the whole thing? We said regular short-acting insulin is preferred for DKA, is preferred for hyperkalemia. With glucose to prevent concomitant hypoglycemia, what they're meaning is when you give insulin to for hyperkalemia, you want to also use glucose because you don't want to go into hypoglycemia. And this is simple. We'll talk about that. And stress hyperglycemia as well. Okay, with that, let's take a look at so the way we're going to do this is first we're going to read it from here. And then we are going to look in this picture. Okay, so now let's talk about the first thing we have is the insulin preparation. Insulin is, we have a couple of preparation for insulin, for example. We have the rapid acting insulin, which is the no lag. No lag is Lispro, Aspart. Names are high yield. Okay, no lag. And the what are they? Like, for example, short acting, regular, rapid acting, high yield. So no lag is Lispro, Aspart, and glue-lysine. And this is the picture of it. Look at the peak. So it starts right away. Rapid acting, meaning it acts right away. Plasma insulin level goes right away up high to the peak and then draws back right away. Time, look at the time. So it has a peak in 1 hour. So if you think about this, peak is about in 1 hour. Okay. And then you have this short acting. So just remember, forget the peak, forget everything. Remember rapid acting, no lag, know the names, Lispro, Aspart, glue-lysine. And because it's a rapid acting, so just think about it. It's the first one. It goes up higher and gets back right away, very quick. Okay. Then you have this short acting. Short acting is your regular insulin. Okay. Regular insulin. Now this regular insulin, is going to be where here. Okay. In this regular insulin, you can see that it has it starts working after 30 minutes. So let me just actually, you don't have to memorize it. So I'm just going to mention all of this part so you have something in the mind. So for the regular insulin, just always what you're going to think of is going to be, it's going to start working within 30 minutes of administration. Okay. 30 minutes of administration is going to start working. And why is that? Because it is dimer and hexamer formation, which takes dimer and hexamer formation, which takes time to dissociate after the injection and causes the absorption delay. Okay. Rapid acting are used to overcome this. So because there is a 30 minutes delay, so you can use these rapid actings, which is Lispro, Aspart, glue-lysine, and they can be used because these are monomers, and they don't need the time to get absorbed into the tissues. So these are monomers, and they get absorbed right after the administration. So what do we learn from this? In this just I mentioned. So this one is monomer. This one is, let's say, dimer. And it needs time for absorption. How much time? Absorption needs 30 minutes. And this right away. Okay. So because it has an action of right away, one high yield point is that these lispro-aspart glulisine, which are rapid acting, they resemble pre-meal related insulin surge. So what do they resemble? Pre-meal. Let me write it down here. Pre-meal. And this is a high yield point that so physiologically, if you want to have some insulin, which normally, when you want to eat a pre-meal, you will have insulin surge. So that is going to resemble by your rapid acting. Okay, let me put it this way. Pre-meal administration of this rapid acting will give you increased insulin secretion post meal. Like after you're done with, you'll have increase in insulin within the bloodstream. So this rapid is going to replicate like pre-meal related insulin surge. Why am I mentioning that? Because first of all, what we do is we give patient, so this is normally we give patient pre-meal. We tell them, hey, when you want to have a meal, inject this insulin. This is going to be your lispro-aspart glulisine. But we will also want to put the patient on something which is going to be the basal insulin, which is going to be your glargine right here. So glargine, this guy replicates basal insulin secretion. So you have something called basal insulin, and you have something called insulin that comes after a meal, normal physiological way. Basal is always there, and this post meal you have insulin surge. So that surge we can give from outside, which is your rapid acting, and to have the patient on a basal insulin levels, which will not mess up the glucose levels, like not going to cause hypoglycemia. These are going to be your glargine. Okay. And why is it basal? Now the question is why this guy is basal, meaning why when we inject it, why doesn't it just go all the way? The whole content just goes into the bloodstream. Why does it stop? Because what we have it precipitates within the subcutaneous tissues. So it precipitates within your subcutaneous tissue and slowly absorbs within the bloodstream. Slow absorption into bloodstream. And that slow absorption gives us that basal insulin. Okay. Some other things you can think of, which is just an extra thinking. You don't have to memorize this part, but it precipitates within the subcutaneous tissue, but also you have to think it precipitates because it has a pH of 4. It has a pH of 4 and forms microprecipitates. So this glargine forms microprecipitates at the site of subcutaneous injection, and then slowly those small precipitates go into the bloodstream, cause the basal insulin levels. The important point is just know which ones are what. So glargine is the basal, while the rapid ones are pre-meal insulins. With that, let's move on to the next part. And that is going to be, so we talked about a short-acting regular, difference between these two, and glargine as well. The next is intermediate acting, which is NPH. Now, intermediate acting NPH, it has, let's look at NPH first here. NPH. Now, for the NPH, it contains protamine and zinc. It contains protamine plus zinc, which prolongs the duration of action but delaying its absorption. Okay, this protamine and zinc will prolong its duration of action and its about duration of absorption and its action, duration of action. With that, let's move on to the next thing, which is called long acting, which is D-Temer and glargine. We talked about glargine, where the D-dimer is going to have. Let's talk about D-dimer now. D-dimer right here. So D-dimer, we have it. It contains fatty acids. So it contains it's so NPH containing protamine plus zinc, right? So this guy contains fatty acid, which binds to lysine amino acids on the insulin molecule. This fatty acid side chain allows D-dimer to bind albumin and slowly dissociate afterwards. So what do we need to know? We need to know that D-dimer binds albumin because of its structure. It binds albumin and slowly dissociate afterwards. Binding of albumin causes its slow dissociation and a long acting. Okay, now we have a very long acting, and that is degludec. Now degludec is where is degludec? If you look at this is a very long acting degludec, but again it goes back, right? So degludec, it contains hexo decannabidiolic acid residues, which polymer formation at injection site and slow uptake. Okay, so what it does is basically it forms the polymers at the site of injection. And that is why it slows uptake. So why did I mention all of this? So I am mentioning all of this because they are details for insulin. Insulin is a high yield topic. So you got to know that these things are somehow, they're all insulin, but the problem is we are trying by their mechanism of actions is the same, but we are trying to delay their absorption, to delay their duration of action by delaying the absorption. Some of them are just forming precipitate, some are monomers, some are dimers, but somehow we are getting our things done by putting some pharmacological additions into our insulin. Now, one more thing that you would have to know is which ones are insulin analogs. So insulin analogs, your regular and NPH, are your insulin analogs. What do I mean by that? They're human DNA recombinant insulins without modification in their amino acid sequence. So they're human DNA recombinant insulins, known as insulin analogs. Okay, and which are to the regular and NPH. With that, let's take a look at the mechanism now. Easy part. Now, the mechanism, you have insulin. Insulin binds its receptor. What receptor binds? A tyrosine kinase, right? When this insulin binds this tyrosine kinase activity, it's going to have its further effects on the organs. So in the liver, you're causing increased glucose storage as glycogen. In the muscle, you're going to cause increase in glycogen and protein synthesis. In the fat, increase in fat storage, which is triglyceride storage. And the cell membrane, high yield, is increase in potassium uptake. High yield potassium uptake. You give more insulin, you are going to cause more uptake of potassium within the cell. Okay. Hypo effect. What are the adverse effects? First, high yield adverse effect of insulin is going to be your hypoglycemia. It causes highest yield is hypoglycemia. Then highest is lipodystrophy. Okay. And then you have hypersensitivity reaction, which is rare. Someone might be being hypersensitive to them. Okay. Weight gain is another problem. Why is it? Now this is also hypoglycemia, weight gain. So now think about it. You have a patient. They're already obese. Let's say they're a type 2 diabetic patient, and they're already obese, right? And their insulin, by the time they come to you, their insulin is already out, meaning they have, if you recall, type 2 diabetes has a progressive beta cell failure. There is failure of the beta cell progressively, meaning it doesn't happen right away, but eventually those type 2 diabetes patient will go into insulin deficiency. So you say, hey, I'm going to put these patients on insulin now because they're deficient. But think about it, they're already obese. You are trying to have, due to the insulin, now they're going to increase their weight. which is weight gain. Now the question is, why would insulin increase the weight? Well, if you look at this, you're causing all that glucose, whatever is in the blood, to go into the tissues, for example, in the liver, form as glycogen, muscle glycogen, and protein synthesis. What do you think is going to cause? What do you think all that fat, all that protein, although you're increasing protein and fat content, what are this going to cause? It's going to cause essentially weight gain, right? Isn't weight gain when you have a lot of fat, a lot of inside? If you look at the subcutaneous fat, after that you got the muscles. So you have both of these things increase, weight gain is there, and that's very problematic. But it is what it is, right? So yeah, with that, just remember hypoglycemia, weight gain. And that is going to be what we have for this. So remember, just one high yield point, glargine has no peak, okay? Well, actually, no peak is by all these long actings have no peak, which is Detemer and glargine. But glargine has no peak here, and digludec for sure no peak. With that, let's just review it. One more high yield point is going to be your insulin C-peptide. When you're giving insulin from outside, what you're not going to see is C-peptide, because you're giving insulin from outside exogenously. Okay, now let's talk about other drugs. We are going to think of two drugs which would increase insulin sensitivity, high yield drugs now. After insulin, we are having this drug to increase the insulin sensitivity. That's going to be one thing is metformin. Second thing is pioglitazone. So first of all, metformin, which is a first-line drug, let's talk about this. So here, what we have is metformin mechanism of action, right? It inhibits mitochondrial glycerol 3-phosphate dehydrogenase, which is M for mitochondrial, GPD for glycerol 3-phosphate dehydrogenase, high yield enzyme. So when you inhibit this enzyme, which is mitochondrial GPD, you are going to cause inhibition of hepatic gluconeogenesis, high yield. So in the hepatocytes, you're inhibiting this mitochondrial enzyme, so you're going to inhibit gluconeogenesis. What is gluconeogenesis? The formation of glucose and the action of glucagon. Okay, both of them will be inhibited. Not only that, it's going, which is not mentioned, not only is going to inhibit this mitochondrial GPD, but also metformin is going to inhibit the complex 1 of the electron transport chain of the enzyme. So it's going to inhibit, let me just put it here, and it's going to inhibit your complex 1 ETC, which is electron transport chain enzyme as well here. Okay, mitochondrial GPD as well as complex 1 will be inhibited, and that is going to cause what? When you inhibit these two things, it's going to cause decreased cellular energy stores. When you decrease cellular energy stores, now the body does not have energy stores, so it needs energy, right? So what it's going to do is it's going to cause increase in, let me just here put it here, increase in AMPK activation. So it's going to activate that AMPK, and that is going to cause decrease. That is going to cause decreased gluconeogenesis, increase in glycolysis. That is going to cause increase in glycolysis. And then when you have increase in glycolysis, you are breaking down that glycogen so that you can have some. That's why it does not cause hypoglycemia, because you have glucose in the blood. It's not going to cause hypoglycemia. Okay. And the second point is peripheral glucose uptake, insulin sensitivity. So let's mention what I talked about, the whole thing again. Mechanism of action of metformin, high yield. It's going to inhibit mitochondrial enzyme, which is GPD, which is going to inhibit hepatic gluconeogenesis. Remember? Hepatic formation of glucose is going to be inhibited. And the action of glucagon will also be inhibited, because if you recall, what was the action of glucagon? To increase gluconeogenesis, to make a lot of glucose, increase glycolysis, to put everything back in bloodstream, right? But you are inhibiting both things, glucagon and gluconeogenesis, high yield point. Second thing, on the lower side, you can think, okay, it also inhibits complex 1, ETC enzymes. But most importantly, it's going to increase glycolysis. Why? Because when you inhibit gluconeogenesis, you're going to have decreased cellular energy store. What do I mean by decreased cellular energy stores? Let's dive a little bit into this. So you will have decreased NADH stores, NADH oxidation. That's one thing. Other than that, you are going to also cause decrease in TCA cycle, and because you're inhibiting your electron transport chain, also you are going to cause decrease in ATP, or because you don't have the glucose, you are going to have low ATP production. All of this is essentially saying that you have decreased energy cellular stores, which in turn would cause increase in glycolysis. So one thing, it is increasing, and other than that, everything is just decreased. What is increased by metformin? Increase in glycolysis. What is glycolysis? Breakdown of glycogen into glucose. It's going to inhibit glycogenolysis, and also inhibit the glycogen effect. And also going to also one high yield point is that, as the name suggests, with an insulin sensitivity, that it is going to uptake glucose. Insulin will increase peripheral glucose uptake, insulin sensitivity. Okay, let's add this chart sort of a thing. So metformin, let's just say metformin, we said it's inhibiting one thing, which is mitochondrial GPD, right? And it is stimulating another thing, and that is called AMP protein kinase. AMP protein kinase. Okay. So when it inhibits this mitochondrial GPD, which is glycerol 3-phosphate dehydrogenase, what it essentially is doing, it's decreasing, and not only it's inhibiting one more thing, it's going to inhibit the complex 1 of your complex 1 of the electron transport chain enzyme. Okay, so comp 1, it inhibits that. So essentially what is causing, due to inhibition of all of this, it's going to cause decrease, let's just mention it here, it's going to cause decrease in glycerol availability. Okay, and then by inhibiting this, it also leads to high yield point, increase in NADH. If you recall something, the pyruvate from your biochem, pyruvate has a lot of places that it didn't go to. One of the things it goes to is called lactate. And the enzyme it needs is lactate dehydrogenase, right? And it needs to convert that NADH into NADs. So when you have a lot of NADH, and when you have low pyruvate because your gluconeogenesis is gone, so what you are going to convert is you are going to take that NADH into formation of NADs and convert all that, whatever is left over, to lactate, one thing. So you have high levels of lactate, one thing. Second thing, normally, lactate normally goes into a TCA cycle, right? But here you're inhibiting the formation of glucose through this TCA cycle. You're inhibiting glucose formation by inhibiting TCA cycle. So lactate is going to more and more is going to have a reverse. You will have increased lactate level because you can move forward. So that a lot of lactate is going to cause lactic acidosis, and that is one of the high yield points in adverse effects, which is your lactic acidosis. Now this lactic acidosis,
you will see lactic acidosis more and more in patients. Now, normally lactate, if you have lactate, either it's going to go into your TCA and to your glucose cause gluconeogenesis, and also it's going to go to the bloodstream, and through renal it's going to get excreted renally. Renally, it will get excreted. So when you have a renal failure, then what's going to happen, which is mentioned here, renal insufficiency, you are going to potentiate the cause of lactic acidosis. So you are going to increase your lactic acidosis. Okay. So this is all about lactic acidosis with renal insufficiency. That's one thing. Now, second thing is, let's change color here, that when you have inhibited mitochondrial glycerol phosphate dehydrogenase, this enzyme is going to inhibit every single thing, leading to you will have low energy stores, meaning you will have you will not go into TCA, no TCA cycle, no ATP production, no ATPs. So when you don't have anything of that sort, this essentially would lead to activation of AMP protein kinase, and that AMP protein kinase activation will cause increase in glycolysis, which is mentioned here, increase in glycolysis. Okay, so this, everything is interconnected. Essentially, all you're increasing is glycolysis, and everything else is decreasing. Decrease in lipogenesis, decrease in gluconeogenesis, decrease in glycerol availability, and everything else. But only one thing, increase in glycolysis through metformin. Okay, with that, let's talk about the adverse effects of metformin. Adverse effects: GI upsets, most common. Lactic acidosis, especially in patients with renal insufficiency, cirrhosis, sepsis, or hypoperfusion. High yield vitamin B12 deficiency. How does it cause vitamin B12 deficiency? Giving metformin. So you have diabetic patient, you started on metformin. This patient developed vitamin B12 deficiency, and it is something similar to neurological findings of vitamin B12 deficiency in diabetes, right? So if you recall, diabetes also causes neuropathies. Vitamin B12 deficiencies also causes neuropathy. So you will think about, hey, maybe patient is developing neuropathy due to diabetes, long-standing diabetes, but you got to check vitamin B12 levels. So what really, how this drug causes vitamin B12 deficiency is by decreasing the absorption of vitamin B12. If metformin is used in long term, decrease in absorption of B12 if you use this drug in long term, and that is high yield point. Second thing is going to be you have weight loss, which is often desired in diabetic patients. Okay. Metformin, it is renally cleared. It is renally cleared. So the absolute contraindication of taking this drug would be somebody, so let's just say absolute contraindication, who cannot take this drug is going to be your patient with CHF and your alcoholics. Absolute, but relative contraindications are going to be that you have a renal failure, or you have a hepatic problem like cirrhosis and all that. Okay. What you have to know is metformin is essentially increasing, as the name suggests up top, you're increasing insulin sensitivity. So there are only two drugs which are going to increase insulin sensitivity. One is metformin and the other one is pioglitazone. So with that, let's talk about pioglitazone. Pioglitazone activates PPAR gamma. Now you got to know the name of this thing. PPAR gamma is your peroxisome. Let me write here. Peroxisome proliferator activator. Proliferator activator. So peroxisome proliferator activator activator gamma. So this thing, PPR is it's a nuclear receptor. So this drug, Pioglitazone, it activates the nuclear receptor, now causing what? Increase in insulin sensitivity. Simple, because you could see that they all are increasing sensitivity of the insulin. It's going to increase sensitivity, and on top of that is also going to increase adiponectin levels. Adiponectin levels. One thing they did not mention, let's just actually, it's high yield to mention. So Pioglitazone goes into the nucleus, right? And within the nucleus is going to activate this PPR gamma. That PPR gamma is then going to activate another thing, which is going to bind. So PPR gamma, which is going to bind to RXR. Okay. And when you have RXR and this guy, okay, wait, let's go back a little bit. PPR binds and activates this. This activates RXR. Why am I mentioning this? Because you got to understand these two things together. PPAR gamma, RXR. When these two are bound together, then you activate the transcription factors. Okay. So when you form a complex between these two, then what happens is they then go and bind DNA, and when they bind the DNA, they have all these effects, which are first of all, you're increasing insulin sensitivity and levels of adiponectin. So a couple other things are going to be decrease in leptin levels, decrease in TNF. Where do I write? Let me just write here. Decrease in TNF alpha, okay, production. And lastly, the last thing that it would increase is increase in free fatty acids or fatty acid uptake. Okay, so three things: it's increasing sensitivity, increasing adiponectin, increasing free fatty acid uptake, decrease leptin, decrease TNF alpha. And these are going to be the mechanism of action of these drugs. This leads to regulation of glucose metabolism and fatty acid storage. Okay. Now, the problem with this drug is you want to lose weight with diabetic patient, right? But here you have a weight gain. So that's why it's not desirable. We don't give it to patients unless necessary, because there is a weight gain and there's an edema here. Edema, heart failure, increased risk of fractures, delayed onset of action, which is several weeks. Why? Because it acts at the transcription factors. It takes time to cause all of its effects because it acts at the DNA level, right? That's why it's going to take some time for everything to work. Now, let's talk about a little bit of adiponectin. What is it, or where it comes from? So if you recall, you have a fat, right? Fat would it's giving off two things. One thing is adiponectin, and second is called leptin, right? So fat cells would release, let's just say release adiponectin and your leptin levels, right? So that adiponectin, the function of this adiponectin is to increase fatty acid oxidation. And leptin, on the other hand, it's going to act on your hypothalamus to decrease appetite. So because you're inhibiting leptin, you are not working on hypothalamus, you're not causing decrease in appetite, essentially going for weight gain, right? That's only one of the things here. But remember, adiponectin is increasing fatty acid oxidation. With that, let's talk about a little more things here, details. So it's going to cause fluid retention. This weight gain is also due to the fact that you are having water retention in these patients. And that water retention will increase the volume. When you increase the volume, you can go into it. First of all, you're going to have edema, which is going to be a peripheral edema. Second thing you can go into is your heart failure. If you have underlying problem of the heart, it can go into decompensated heart failure with the underlying CHF. Okay. With that, let's just review these two drugs and move on to the next. So we were talking about two drugs, Yeild, Metformin. Metformin is going to increase glycolysis, which is your breakdown of glycogen, and increase insulin sensitivity, Yeild. Other than that, it's just going to inhibit mitochondrial enzymes, which is GPD, and it's going to also stimulate AMPK activation, which is AMPK activation, which causes increase in glycolysis. Yeild GI upset lactic acidosis, vitamin B12 deficiency, and weight loss. Pioglitazone will activate PPR gamma, which is going to bind to its binds to RXR. Okay. And this complex then goes into and binds DNA, leading to further action, which is increase insulin, increase adiponectin, increase fatty acid uptake, decrease in your leptins, and decrease in TNF alpha production. The problem with this drug is going to cause weight gain, edema, which weight gain due to decrease in leptin and due to increase in leptin and increase in water retention, essentially causing weight gain. But that water retention not only going to cause weight gain, but also peripheral edema. It's going to cause decompensated heart failure and increased risk of fractures. It is of delayed onset of action because it goes and alters gene transcription and protein synthesis, which takes time. And that is all for insulin sensitivity. Let's talk about other drugs, and that are going to give you increased insulin secretion. So insulin secretion can be increased by your secretagogues, right? These two are secretagogues, sulfonylureas, first generation, second generation, and Meglitinides. So let's talk about each one of them. Sulfonylureas, first generation, we have chlorpropamide, tolbutamide. Second generation, we have glipizide and glyburide. And then you have Meglitinides. We have netiglinide and ripaglinide. Okay, so what's the difference between all of them? Second generation, not just second generation, but the whole thing, all the sulfonylureas are longer acting, or actually not that, but just the second generation, glipizide and glyburide, they are longer acting. And Meglitinides, they are short acting. Short acting meaning they work about 1 hour. Short acting and long acting. Second generation, first generation. So let's talk about mechanism of action, which is Yeild. So the mechanism, it's going to close potassium channel in the pancreatic beta cell membrane, which leads to cell depolarization, insulin release via increase in calcium influx. With that, I think it's better to visualize this in the physiology, which I did talk about in insulin, but we'll just quickly look at that. Where is it? Okay, here we go. So we have sulfonylureas are going to act on this channel, which is your potassium channel. So it's going to close. They have mentioned it here as well somewhere. Let's read. Sulfonylureas. Here you go. So it's going to close potassium channel, which is the target of sulfonylurea. So what normally happens is you have a glucose. Okay, glucose gets in. Glucose forms ATP when there is an increased ADP to ADP ratio, meaning when there is increased ADP due to the fact that you got the glucose in there. That ATP is going to bind to this ATP-sensitive potassium channel. When ATP binds to this channel, it essentially closes this channel. When it closes this potassium channel, the cell is going to go into depolarization. When the cell goes to depolarization, there's an activation or there's an opening of calcium channel. Okay, when the calcium channel opens, calcium comes in the cell, you increase intracellular calcium, and that intracellular calcium will cause exocytosis of insulin granules. And you can see granules of insulin going out in the bloodstream. That's the normal mechanism of action. Now, there is, let's talk about another drug, sulfonylureas, right? Sulfonylurea is going to inhibit or stop this channel. It's going to close this channel out, which was normally closed when you had an ATP. And when would you have an ATP? When you have glucose. When would you have glucose? When you have in the bloodstream, when the glucose is there, that glucose come in, form ATP, it's going to close. But now we have something from outside we give, that is the sulfonylureas, and that drug closes channel. When you close this ATP-sensitive potassium channel, essentially you're going into normal physiology again. When you close this channel, you're going to depolarize the cell membrane, causing calcium channels to open. More and more calcium will come in, cause exocytosis of insulin granules, and the insulin will release out. Okay? So that is the mechanism of action of sulfonylureas, inhibiting potassium channel. Look, with that, let's go back to the form. Okay, let's read. So we have insulin secretion, increased insulin secretion. By closing that potassium channel in the pancreatic beta cell, it leads to cell depolarization, which causes insulin release while increased calcium influx. 100%, right? And this insulin release, one high yield point is, it is independent of glucose concentration in the blood, right? Because it doesn't matter you have glucose or not, or essentially you have glucose formation of ATP or not, because you are just from outside, you're inhibiting that ATP potassium channel. So you don't care if you have glucose or not. So it is independent of glucose concentration, blood glucose concentration. So now the problem arises when they don't even care if you have insulin or not. You give this drug, and let's say the patient didn't eat anything, or the patient is in fasting state, and this drug is doing its action, they are going to cause what? Hypoglycemia, high yield, hypoglycemia. Okay, high yield. With these drugs, which increase insulin secretion, they are going to cause hypoglycemia, which is you did not see with any other drug yet we talked about. Nothing with insulin sensitivity. Metformin does not cause hypoglycemia because it is increasing glycolysis, meaning increase in glucose in blood, but nothing about hypoglycemia. But these drugs, which increase high yield, drugs which increase insulin secretion endogenously, will cause hypoglycemia. And exogenously, if you give insulin, will also cause hypoglycemia, which is here. You would undergo hypoglycemia if you give insulin from outside. Okay, that's understandable. But this one is high yield also, that it's going to cause hypoglycemia. especially with your long-acting drugs, especially with the long-acting sulfonylureas than your shorter-acting sulfonylureas. Okay, with that, let's talk about the adverse effects here. The adverse effects are disulfiram-like reaction because of first-generation sulfonylureas, as the name suggests, right? Sulfa, it contains sulfa. So sulfa will give you disulfiram-like reaction, hypersensitivity reactions. Okay. Now, hypoglycemia with increased risk in renal insufficiency. Okay. And weight gain. Again, weight gain is a problem here. Hypoglycemia and weight gain. So you will have hypoglycemia risk especially in elderly patients with hepatic impairment or renal failure. Elderly patient with hepatic impairment or renal failure, or patients who exercise, or a patient who missed meds, acute illness, or when you add new diabetic drug, new anti-diabetic drug. All of these are risk factors of causing hypoglycemia in patients who are taking any of this drug. Okay. One other high yield point is this hypoglycemia. Okay, you got a patient of hypoglycemia. Okay, fortunately, they came in the ER. But now the problem is that this can reoccur. Why? Because even if you fixed the first initial hypoglycemic state, okay, until the drug is in the body, it can, again, stimulate its cells, causing inhibition of the potassium channel, causing increase in insulin release, and that is going to cause hypoglycemia until the drug is cleared out of the body. And that depends upon which drug you gave. Did you give it? Did the patient had a short-acting drug or longer-acting drugs? Okay. With that, that's pretty much what we have for this. So let's quickly review this. Insulin secretion, sulfonylureas, first, second generation, and meglitinides. Second generations are your longer acting. Meglitinides are your shorter acting. They are going to block or close your potassium channel. When you close it, you are going to cause cell depolarization and calcium influx and then insulin release. There's also sulfur drugs, so disulfiram-like reaction, specifically or especially with your first generation sulfonylureas. And because they are causing insulin release, they are going to cause hypoglycemia, especially in your elderly with renal failure, renal insufficiency, hepatic failure, exercise, taking another, adding another anti-diabetic medication, or your acute illness, or missing a meal. All are the risk factors for hypoglycemia, and they are going to cause weight gain. And that is all for sulfonylureas and meglitinides. Let's move on with the increased glucose-induced insulin release. So these are the drugs which are going to cause insulin release, but they depend on glucose levels. They depend on blood glucose levels. For that, we have the first one are going to be GLP-1 analogs, exenatide, liraglutide, and semaglutide. And then DPP-4 inhibitors, linagliptin, saxagliptin, sitagliptin. Okay, with that, let's talk about the first one, which is the GLP-1 analogs. GLP-1 analogs are going to cause, if you recall your GI, they are the incretins. Let's just mention them here. Incretins. incretins, what they do is when you take glucose, when you take food, okay, they go in the stomach, they stimulate incretins. Those incretins, which are your GLPs and GIPs, they go on to the beta cell, pancreatic beta cell, and cause insulin release. Insulin release. But again, they're dependent on the food itself. Okay. With that, let's look at the mechanism of action. So first of all, here, the important thing, increase glucose-dependent insulin release. So they are going to cause increased insulin. When they are causing increase in insulin, they got to stop the other one, which is glucagon, which is the opposite of insulin. So decrease in glucagon release. And the other thing they do, which is very important, is decrease in gastric emptying. So let's say you had a meal, that food is here. When you delay the gastric emptying, let's say from here, let's say this food only took like 2 hours. Normally it would take 2 hours to be cleared from the stomach. But now, since these drugs are there, they're going to delay the gastric emptying. Now this food is going to be in the stomach for about 4 or 6 hours, let's say. So you're going to feel full, right? So that is why it is increasing its satiety. It is a drug which causes weight loss. High Yeild. This is right now, I mean, it's all over the market for the weight loss in diabetic patients. Okay. But this one is orally given, but right now the ones in the market for the weight loss in diabetic patients are the subcutaneous. Okay. But again, the same thing, GLP analogs. Okay, let's talk about its adverse effects: nausea, vomiting, pancreatitis, weight loss, often desired, and increase in satiety. Okay, so let's talk about now the DPP4. It's a very simple thing. So if you understand this, let's say you have food. This goes into the intestines and then secrete the GLP-1s, let's say. That GLP-1 then goes on the beta cells of the pancreas. Now, there is something which destroys this GLP-1, right? And that is your DPP4. The name for DPP4 is dipeptidyl peptidase 4. So let me write this down. Dipeptidyl peptidase 4. Peptidase 4. So this guy, DPP4, inhibits this, well, not inhibits, but leads to GLP-1 would be metabolized by this enzyme into inactive metabolites, right? So now the function is, first of all, we are giving this drug, right? And now what we want to do is we don't want to destroy it. So we give inhibitor of DPP4, which is your linagliptin, saxagliptin, and sitagliptin. With that, let's read. So when you inhibit this, and you have more and more of GLP-1, and it's going to cause beta cell to be more sensitive to glucose, an increase in insulin secretion, glucose-dependent insulin secretion, meaning glucose has to be there to cause insulin secretion. So guess what? You're not going to cause hypoglycemia because glucose is there. Glucose-dependent, high yield. Okay, so with that, let's look at DPP4, and then we will just overview the whole thing. It inhibits DPP4, which is dipeptidyl peptidase 4 enzyme that deactivates GLP-1, which leads to, when you inhibit this enzyme, it's going to cause decrease in glucagon release, which is essentially the same thing up top, decrease in gastric emptying, and increase in glucose-dependent insulin release. Okay? Now, adverse effects is going to cause respiratory and urinary infections, and weight is neutral with this. An increase in satiety, which is often desired. Okay. Now, high yield point is this: DPP4 is going to cause these two infections. Now, urinary or respiratory infections, so nasopharyngitis, pharyngitis can be caused by this drug. So let's review this. So GLP-1 analogs and DPP-4 inhibitors, essentially the same mechanism of action. So all you have is GLP working on the pancreatic beta cells and GLP getting degraded by DPP4. You could inhibit DPP4 by giving these drugs and increasing GLP, and GLP would cause increase in insulin release, in glucose-dependent insulin release, decrease in glucagon, and decrease in gastric emptying, essentially causing weight loss and increase in satiety. Because it is working on the pancreas, that's how it's going to cause pancreatitis. Okay, and nausea, vomiting is just there with most drugs. With DPP4, something new is here now, which is your respiratory and urinary infections. Respiratory nasopharyngitis, that's important. Nasopharyngitis, and also UTIs. Okay, and with that, let's move on to the next ones. So now let's talk about what are the drugs which are going to decrease glucose absorption. Okay, so there are two. One is SGLT2 inhibitors, sodium glucose transport 2 inhibitors, and your α-glucosidase inhibitors. So if you recall, you have, let's actually draw this here for a better understanding. So let's read the mechanism of action, and then I'm going to draw this one quickly. So SGLT2 inhibitors, they are going to block the reabsorption of glucose in the PCT, proximal convoluted tubule, leading to glucosuria, meaning glucose will go out in urine. Also cause natriuresis and osmotic diuresis. We will talk about natriuresis, how that's going on, and osmotic diuresis also, which will lead to decrease in blood glucose because you're throwing out all that glucose. For sure, you're going to have decreased glucose levels, decrease in serum potassium because you're going for throwing out that sodium. For sure, you're going to have low sodium and low ECF volume because of diuresis. And when you have low volume, you're going to have hypotension or decrease in blood pressure. With that, let's look at this mechanism. Where do I draw this? So let's just draw it here. So SGLT, so if you recall, in the PCT, you have glucose sodium cotransporter channel in the PCT. So this is your lumen, which is essentially saying urine. And this is going to be your blood. And this is the actual PCT cells. So you have glucose and sodium, which would get reabsorbed in the PCT, which would get reabsorbed in the PCT. Now, if can you recall how much normally is reabsorbed, or normally how much glucose is reabsorbed in PCT? That's 90%. 90% of 90% of glucose gets reabsorbed where? In the PCT, at the very start. Okay, the very start, everything, almost 90% is going to get reabsorbed in the PCT, the glucose. Okay, so that 90% will get reabsorbed, and from here, that glucose is going to go into the blood by the GLUT2 transporters. So GLUT2 transporters, and they will take that glucose back into the blood. Okay, So now when we knock this out, when we stop this, or when we block this channel by giving SGLT2 inhibitors, we block this channel. So in the lumen or in the urine, what are we going to have? We're going to have all that 90% of glucose and all that sodium. When the whole sodium and glucose is there, it's going to cause a couple things, right? That all that glucose is going to go out in urine, causing glycosuria. All that sodium is going to go in urine, cause natriuresis, right? And when you have all of these solutes going out, you're going to draw more. They're going to draw more water in, so all that water will go out with it, and that is called osmotic diuresis. Osmotic diuresis, right? And when you lose all that water in the blood, you're not going to have a lot of fluid, so you will decrease extracellular fluid volume. You're going to decrease your blood pressure, right? And that essentially is everything we talked about up top. Block reabsorption, glucosuria, natriuresis, osmotic diuresis, serum low, but sodium low, ECF low pressure, and low glucose. Okay, but now the problem is when you're putting all that glucose in the urine, that is going to develop UTIs, high yield point. These drugs are going to cause UTIs because all that glucose will be eaten up by the microorganisms, causing UTIs, vaginal candidiasis. Okay, that's also very high yield. Okay, not only UTIs, but also vulvovaginal candidiasis, dehydration because low blood, leading to low blood volume, causing dehydration, leading to dehydration, and that will lead to orthostatic hypotension. Weight loss is there because you're losing all that glucose. For sure, you're going to have weight loss. So glucose flows in urine, and that's the flozins. Flozin is the drug. All these drugs have similar name, flozins. The mnemonic they have is glucose flows in urine. Use with caution in renal insufficiency. So why? Because it acts through renal, right? So when you have low efficacy, or when you have renal insufficiency, you're going to have low efficacy, because low efficacy essentially means that drugs are not working, because drugs have to go into the PCT to stop this transporter. So when they can't even reach there, they cannot do their mechanism. So there will be low efficacy with renal insufficiency, with low GFR, right? Renal insufficiency will have low GFR, meaning the plasma can't go there, right? There is a decrease in GFR, glomerular filtration rate. So when you have a decreased GFR, you have low efficacy of these drugs, because these drugs can't reach there. Okay. With that, let's talk about the last one here, which is your alpha-glucosidase inhibitors. Now, glucosidase inhibitors, it is the glucoside. So you got to know this thing, alpha-glucosidase, it's an intestinal brush butter enzyme. So these drugs, which are the inhibitors of this intestinal brush butter enzyme, alpha-glucosidase, when you inhibit this enzyme, alpha-glucosidase, is going to cause delayed carbohydrate hydrolysis. So normally you have a starch. Starch will be broken down into glucose by alpha-glucosidase. Now, when you knock this enzyme out, you cannot. There is no formation of glucose. So all you have is delayed carbohydrate hydrolysis. There is no hydrolysis, or there's a delayed hydrolysis. And when you don't form glucose, there is a low absorption of glucose. It will cause decreased postprandial hyperglycemia. Decrease. Look at that level. It's saying decrease, meaning you're not going to cause postprandial hyperglycemia. Okay. Why? Because postprandial means after you have a food, you took some food. Here you go. You had dinner. Now that all that food cannot get into glucose because you have inhibited the enzyme. α-glucosidase, and that is not going to cause hyperglycemia because the glucose didn't even reach the bloodstream. Okay. But still, what you got to know, because it is remaining within GI, it's going to cause GI abscess and bloating. Not recommended with renal insufficiency. Okay. With that, we have the last drugs, which are your amylin analogs. Amylin analogs are your pramlintide. This pramlintide is going to cause something similar to your GLP-1s, which is to decrease glucagon release and decrease gastric emptying. Okay. And with that, it's going to cause hypoglycemia, nausea, and increase in satiety. Decreased gastric emptying will cause increase in satiety. Decrease in glucagon release. If you recall, in the fasting state, glucagon is the one which normalizes glucose levels and doesn't let us go into hypoglycemia in the fasting state. So, but when you are inhibiting or when you're decreasing glucagon, for sure you can go into hypoglycemia. And that is all we have for these drugs. All right, I want to add some point for metformin. All right, so 2 drugs we need to check before we initiate these drugs. We got to look at their renal function tests. So one is metformin. Before we initiate metformin, we have to look at the serum creatinine levels to estimate GFR. We have to check for the renal function test before initiating metformin. Okay, that's one thing. And another drug that we also look for the GFR is going to be your SGLT2 inhibitors. For these drugs, before we start on these drugs, we check for GFR, which is the renal function test, by checking serum creatinine levels. Okay, so serum creatinine levels to estimate GFR. So 2 drugs, we check renal function tests. Now, let's add one more important thing. Which drugs are causing fluid overload and which are causing volume depletion? So these, the glitazones, the pioglitazones, they are causing fluid retention. Okay, they're causing fluid retention, and SGLT2s are causing volume depletion. Volume depletion leading to high orthostatic hypertension. Okay, and with that, let's move on to the next. So now let's talk about thiamides. We have propylthiouracil and methimazole. Mechanism of action for these drugs, they block thyroid peroxidase, your TPO, thyroid peroxidase enzyme, which will lead to inhibition of oxidation, organification, and coupling. 3 things. So again, inhibition of oxidation of iodide, as well as organification and coupling of iodine, which essentially causes inhibition of thyroid hormone synthesis. Simple. When you are inhibiting this enzyme, you're inhibiting thyroid hormone synthesis. PTU also blocks another enzyme known as 5'-deiodinase, which causes, if you recall, you had a T4 which converts into T3 and a reverse T3 by an enzyme which is 5'-deiodinase. When you knock this out, when you knock out this enzyme by giving PTU, you cannot form T3 or reverse T3. So you will have a decrease peripheral conversion of T4 to T3. And if you recall, T3 is more active than T4 itself. Okay. The way we can remember is by P's. P for PTU and P for peripheral conversion. Okay. But let me ask you, what other drugs would block this enzyme which has the peripheral conversion? 5'-deiodinase 5' deiodinase. Well, if you're saying beta blocker, you're right. Beta blockers are going to block this enzyme, so causing decreased peripheral conversion of T4 to T3. If you're saying glucocorticoids, then you're right, glucocorticoids. And if you're saying, lastly, IPOD8, which is the contrast agent, then you're also right. So these four things, 1, 2, 3, 4, they are going to inhibit 5' deiodinases, which are going to cause decrease in peripheral conversion. With that, let's look at the clinical use of these thiamides. They are used in hyperthyroidism because you're trying to block the inhibition of thyroid synthesis, of course, used in hyperthyroidism. Now, PDU is used primary first trimester of the pregnancy due to methimazole tetragenicity. Okay, methimazole is started in second and third trimester of pregnancy due to risk of PDU-induced hepatotoxicity, high yield points. So P is for a lot of things. So P here, propylthiouracil for pregnancy, propylthiouracil for the peripheral conversion, right? But only in the first pregnancy, only in the first trimester. Why? Because in the first trimester, we have methimazole, which is teratogenic. And which we'll talk about in repro, that how teratogenicity mostly affects in the first trimester. But again, we're not just switching on the drugs just because second trimester is relatively safer, but due to PTU causing hepatotoxicity, that's more dangerous at that point than causing tetragenicity, which has lesser effect by second and third trimester, which we'll talk about in repro. Okay. So again, very high yield PDU first trimester. So P primary, that's very good mnemonic. P primary, remember, first trimester. And then methimazole, second and third trimester. But now after the pregnancy, we put the patient back. So let's read this. Methimazole uses second, third trimester due to risk of PDU, hepatotoxicity. Not used to treat Graves' ophthalmopathy. And Graves' ophthalmopathy has to be treated by glucocorticoids, high yield. Because Graves' ophthalmopathy is due to the fact that you have all that inflammation going on, those cytokines being released, which causes increase in GAGs, and that causes exothelmos, right? So in order to inhibit all that inflammation cytokines leading to increase in GAGs, the PDU or methimazole are not going to do anything, but you have to inhibit all this inflammation in order to inhibit the GAGs, in order to not have exothelmos. So to do that, you got to give glucocorticoids. Steroids are going to inhibit all that inflammation. Okay. High yield point. Graves' ophthalmopathy can be treated by glucocorticoids. Now, adverse effects. Actually, before we go on to adverse effects, so after the pregnancy after pregnancy, we put the patient back on PTU. Okay. So now let's look at adverse effects. Adverse effects, skin rash. Okay, important with all these drugs, skin rash, but more important, agranulocytosis, high yield. With these drugs, you are causing agranulocytosis. It's sometimes called drug-induced neutropenia. Let me write it down. Drug-induced neutropenia. Okay. And the clinical features of this patient who's taking these drugs for hyperthyroid will come in with fever, oropharyngeal ulcers, after starting these meds due to agranulocytosis. So what is the treatment if someone comes with this? So treatment is, first of all, remember to stop the drug. Although this looks very, it's there, but sometimes you forget this. Stop the drug. You have to stop this drug, first point. Okay. And when you stop this drug, agranulocytosis will self-resolve. Okay. So we talked about skin rash, agranulocytosis, aplastic anemia. hepatotoxicity, which is the PDU. PDU can be associated with ANCA-positive vasculitis. Okay, methimazole is possible. Tetrogen can cause aplastic cutis. Okay. And that's going to be all for thiamides. So let's quickly recall thiamides, propylthiouracil, which is PTU, and methimazole. They block TPO, which is thyroid peroxidase, leading to inhibition of thyroid peroxidase synthesis. When they block TPO, they're blocking essentially three things: oxidation, organification, and coupling, leading to inhibition of thyroid peroxidase synthesis. PDU has another function as well. It's going to block the peripheral conversion by blocking 5' deiodinases. And beta blocker will also do the same thing. Corticosteroid is going to do the same thing. And IPOD8, which is a contrast agent, is going to do the same thing, blocking this peripheral conversion. We give these drugs in hyperthyroid patients, and the patient could be patient could be pregnant by the time we give this drug. So we have to switch. For example, the patient is taking PTU. We have to keep PTU for the primary, meaning first trimester, and the second and third trimester, we switch to methimazole. Why? Because PTU is hepatotoxic and methimazole is teratogenic. That's why we don't initiate it first. And that is why for the second one, PTU, we don't keep it all the way because it is hepatotoxic. Graves' ophthalmopathy can be treated by glucocorticoids. Adverse effects: skin rash high yield with agranulocytosis. With agranulocytosis, you can say aplastic anemia and hepatotoxicity. PTU is associated with ANCA-positive vasculitis and methimazole with aplasia cutis. With that, let's move on to the next one, which is levothyroxine and liothyronine. Mechanism of action of these drugs are their hormone replacement for T4, which is levothyroxine, levo 4 letters, or liothyronine, which is 3 letters. Okay. A wide levothyroxine with antacids, high yield point. A wide levothyroxine with antacids, bile acid resins, or ferrous sulfate. Not only this, but let's add some more. Calcium, iron, calcium, and antacids. So let's add calcium, which is not here. So we talked about iron, calcium, and antacids, and bile acid resins. Why? Because when you co-administer a levothyroxine with these drugs, it's going to cause decreased absorption of levothyroxine. Okay, that is why we do not co-administer antacids, bile acid resins, iron, and calcium. Remember, iron, calcium, antacids. You don't co-administer with levothyroxine, as it will decrease absorption of levothyroxine. High yield point. Okay. Let's talk about the clinical uses. Clinical uses are hypothyroidism. Of course, you want to give thyroid hormones if the patient isn't having hypothyroid. Myxedema may be misused for weight loss. Distinguish exogenous hyperthyroid from endogenous hyperthyroid by using a combination of TSH receptor antibodies, radioiodine uptake, and or measurements of the thyroid blood flow on ultrasound. So all they're saying is, okay, if you want to distinguish someone who's taken from outside these hormones, or is due to the fact that you have endogenous hormone production, how you can tell the differentiation by looking at, do you have any antibodies, TSH receptor antibody, which are stimulating the thyroid hormone formation, leading to formation of hyperthyroidism? Or you take a look at radioactive iodine uptake. How much iodine has been uptaken by the thyroid itself, and look at the blood flow of the thyroid on ultrasound. Okay, so if you're taking someone is taken from outside, their thyroid will not be functioning a lot, right? So their blood flow is going to be low. Their radioactive iodine uptake is going to be low. But someone who is endogenously having hyperthyroid, for sure their blood flow to the thyroid is going to be high. Their iodine uptake is going to be high. So that's how you differentiate between exogenous versus endogenous thyroid. Okay. Adverse effects are going to be your tachycardia, heat intolerance, tremors, arrhythmia, high yield. All of that, which you see in hyperthyroidism, not hypo, but hyperthyroidism, is going to be tachy, heat intolerance, tremors, arrhythmias, right? That's all with the hyperthyroid. And that's pretty much what we have for these two. Then we have hypothalamic-pituitary drugs, in which we have this Conivaptan, tolvaptan. So vaptans, all the vaptans, they are ADH antagonists. Okay, and they're used in SIADH because they block the ADH receptor at V2 receptors. Okay. And then you have Demeclocycline, which is again ADH antagonist, which is a tetracycline, also used in SIADH, interferes with ADH signaling. Desmopressin is analog now. These two were antagonists. This is analog. It is used for DI, diabetes insipidus, central diabetes insipidus, and von Willebrand factor disease. Because if you recall, von Willebrand factor, desmopressin stimulates endothelin that leads to release of von Willebrand factor. So that is what we need. If we don't have if we have von Willebrand factor disease, we can give we can give desmopressin, which is going to stimulate endothelin, and it's going to release von Willebrand factor with also factor 8. Okay, sleep and uresis. In sleep, if there is urination, you give desmopressin, which is an ADH analog, which is going to reabsorb all that water. Anti-diuretic hormone. No diuresis, meaning no urination, right? So sleep and uresis, you can give in sleep and uresis to have decreased urination. Hemophilia A, 8, again, factor 8 inhibition, the deficiency, right? And you can give this drug, which is going to act on endothelin release, von Willebrand factor, which also has factor 8 in hemophilia A. Oxytocin. Oxytocin is induction of labor, right? High yield point, induces labor, stimulates the uterine contractions, and control uterine hemorrhage. Because of all that contraction, you contract those blood vessels which are dilated. Of course, you're going to decrease the hemorrhage, right? Because of that muscle contracting. So it's going to decrease that, decrease the amount of hemorrhage that you can go into. So high yield point for oxytocin is that induction of labor and control uterine hemorrhage. Octreotide is a somatostatin analog. It is used in acromegaly, carcinoid, gastronoma, glucagonoma, esophageal varices. When we talk about octreotide or somatostatin, we said this is going to be a blanket of hormones. It's a blanket for all hormones, meaning it's going to inhibit every single hormone. So that is why we give an acromegaly. We want to inhibit growth hormone. Carcinoid tumors, we want to inhibit serotonin. Gastronoma, we want to inhibit gastrin. Glucagonoma, glucagon, esophageal varices, we want to decrease the blood at the varices. Okay. All right. With that, next one we have is called Fludrocortisone. Fludrocortisone is a synthetic analog of aldosterone with glucocorticoid effects. Fludrocortisone, meaning simple thing, fluid. Fludrocortisone retains fluid because that is the function of aldosterone, right? So fluid, it's very easy the way they have mentioned it here. Fludrocortisone. Instead of calling it fludro, just call it fluid cortisone. It is an aldosterone plus glucocorticoid, which is your cortisol. Okay. So clinical use, if you have mineralocorticoid replacement, which one is mineralocorticoid? That's again your aldosterone. If you want to go for aldosterone replacement in your primary adrenal insufficiency, you give this drug, which is fluid fludrocortisone or fludrocortisone. Adverse effect is similar to glucocorticoid. Also edema, exacerbation of heart failure, and hyperpigmentation. Okay, again, edema and all that, fluid retention, because it has the work of aldosterone. It has the work of aldosterone. Before we move on to the next page, let's actually talk a little more of things. So we did talk about how we have, we treat hyperthyroidism, hypothyroidism, right? But if it is not, you can also give radioactive ablation. Let me just write it down here for thyroid. So thyroid for Thionamides, levothyroxine, and liothyronine. Another thing we can give is your radioiodine ablation. Radioiodine ablation. So you can give a radioiodine, which is then taken up by the thyroid, and it causes ablation of the thyroid tissue itself. And then it's going to cause, now the adverse effect will be permanent hypothyroidism and worsening of ophthalmopathy and possible radiation side effects. Radiation side effects will be there. Or the next thing you can give for hyperthyroidism is you can have them go into surgically remove the thyroid, right? Now, again, the adverse effect of this surgery is going to be, again, your permanent hypothyroidism. But now, because of surgery, so there is risk of cutting down your parathyroid. So hypoparathyroidism is a risk. And recurrent or superficial laryngeal nerve damage is a risk, which can lead to hoarse voice or low pitch voice, all that. Okay. With that, let's move on to the next page. Okay, let's add in one thing here. I want to add beta blocker. Let me write it down here. So recall that we use beta blocker to inhibit what? The peripheral T4 into T3, right? We inhibited that by inhibiting which enzyme? 5' deiodinase or monodeiodinase, anything. But essentially it's inhibiting T4 to T3. Now, you have to know one thing, that if you recall, your hyperthyroid would cause increase in beta receptors, right, on the cells, everywhere actually. When you increase the beta receptors, it's the patient is, due to the fact that you're increasing beta receptors, that is why the patients with hyperthyroidism develop tremors, tachycardia, hypertension leading to hypertension, and hyperreflexia. I mean, there are other things due to the fact that you have beta-adrenergic manifestations, so hyperreflexia, all of these sort of things, right? So giving a beta blocker would blunt all these beta-adrenergic signs and symptoms. Okay. In addition, what we do is, for example, giving beta blocker like lipid soluble beta blocker. Let's just write it here. Lipid soluble beta blocker like propranolol is used, which would propranolol, because it's a lipid soluble, is going to inhibit. It's going to go into the cell. Is going to inhibit that. Excuse me. Is going to inhibit that T4 to T3 conversion because it is lipid soluble. That's one thing. Second thing I would like to mention about potassium iodide, which is Ki. So potassium iodide inhibits the release of T4, T3 from thyroid. When do we use this potassium iodide? Now, we use this potassium iodide to inhibit the uptake let's say there is a nuclear accident or something, that thyroid would take anything that you have iodide with, right? Doesn't matter your nuclear accident, anything, it's going to take that I-131, which is radioactive iodide. It's going to take that and it's going to cause thyroid carcinoma, right? So in nuclear accident, what we do is we give from outside, we give potassium iodide, so that it does not, the thyroid does not take that radioactive iodide. Instead, it takes this potassium iodide, and we're trying to save the thyroid from developing thyroid carcinoma. Okay, that's another high yield point. With that, that's pretty much all we have for thyroid. Let's look at now the drug Cinacalcet. Now this mechanism is, it sensitizes calcium sensing receptor CSRs. If you recall, you have a parathyroid. On top of parathyroid, you have a receptor known as CSR. Okay, and CSR is continuously sensing calcium levels. Okay, so this Cinacalcet would sensitize CSRs to circulating calciums, leading to decrease in PTH. Pronounced Cinacalcet. Cina for sensitizing calcium channels. So let's talk about normal. Normally, when calcium binds to CSR, it's going to decrease PTH release. And if the calcium does not bind to CSR, it's going to cause increase in PTH release. That's normal physiology, right? Now with this drug, Cinacalcet, it sensitizes CSR that even if there is a low calcium level, it's still going to bind to this CSR and it's going to decrease PTH secretion. Simple, right? Now, clinical use is secondary hyperparathyroidism in patients with CKD receiving hemodialysis, hypercalcemia, in primary hyperparathyroidism if parathyroidectomy fails, or in parathyroid carcinoma. So essentially, all you want to think about whenever you have increase in PTH, no matter what the cause is, you have normal, everything else is normal except you have increase in PTH. You want to give this drug so that you can decrease the PTH levels. Okay, that's what we have. Adverse effects, hypocalcemia, because when you're decreasing PTH, of course, you can go into a hypocalcemic state. Simple as that. But got to know the name, Cinacalcet. This mnemonic is very good. Cinacalcet, meaning sensitizes this calcium to the CSRs, so you decrease PTH. Simple. Then you have this another drug called Sevelamer or Sevelamer. Mechanism of this drug, it is a non-absorbable phosphate binder. It's going to bind all that phosphate, dump it out, and prevents phosphate absorption from GI tract. Simple. There is phosphate in GI. This drug, Sevelamer or Sevelamer, whatever it is, just remember it. It's going to bind that phosphate, dump it out, so you don't absorb it in the GI tract. Clinical use, if you have hyperphosphatemia in your CKD, recall that the phosphate has to go out through renal, right? In your CKD, you have chronic kidney disease. You can't dump that phosphate out. When you can't dump that phosphate out, all that phosphate remains within serum, leading to increased level of phosphate, which is essentially called hyperphosphatemia. So you could give Sevelamer, which is going to bind that phosphate, dump it out, so you don't even have the absorption of that phosphate in the first place, right? Now, adverse effect is, again, when you're dumping out that phosphate, you're going to go into hypophosphatemia and GI upsets because it's all into GI. Okay. Simple things, but got to know the names: Sevelamer and Cinacalcet. Calcium sensing receptor, phosphate binder. Then next we have this cation exchange resins, in which we have Patiromer, whatever you can call it. Patiromer sodium polystyrene sulfonate, sodium polystyrene sulfonate, zirconium cyclosilicate. Wow. Cation exchange resins. Well, these guys, they are going to bind potassium in the colon in exchange for other cations, for example, sodium, calcium, leads to potassium excretion in feces. Okay. P for Patiromer, P for potassium, okay. Sodium polystyrene sulfonate. I mean, this one has sodium, so I mean, I can't really think of. Then you have the zirconium, whatever that is. But remember, what are they doing? They're all binding potassium, and in exchange for other cations. Again, these are cation resins. They are going to bind potassium in exchange for other cations. One thing we talked about is sodium. The other one may be from cyclosilicate. We can think about calcium, whatever. But the high yield point is they're going to throw out that potassium. Got to know the names. Okay. This is a memory. Got to memorize these things. Because it's going to throw out that potassium, you're going to have used in hyperkalemia, and it's going to cause hypokalemia. But this one is easy. Patiromer potassium resin. Okay. With that, let's talk about some other drugs. For example, calcitriol, TRIOL. And calcitriol is an active form of vitamin D. Okay. It is used to treat and prevent post-operative decreased calcium due to surgical removal of the parathyroid while thyroidectomy. Okay, important. So calcitriol, as you know, this is an active vitamin D, one thing. Now, you would give this drug to prevent in patients with post-operative low calcium. Why would you have post-operative low calcium? When you have thyroidectomy, there is risk of removal of parathyroid gland as well. So when you knock out your parathyroid glands or remove them, you are going to cause low calcium post-operatively. So you give calcitriol. Okay, that's important. Other than that, we're pretty much clear. Last thing I want to mention about, we talked about how we have GnRH analogs, last thing here, GnRH analog, like for example, leuprolide, GnRH analogs. So when we administer GnRH analog in a pulsatile fashion, meaning when you give the drug not continuously but in pulsatile fashion, what you're going to get is a transient increase in its action. For example, increase in FSH, increase in LH, and that's going to cause increase in testosterone production and all that, right? But pulsatile is high yield. But when you give the same thing, when you give a continuous GnRH analog continuously, it's going to suppress the same thing it was stimulating, meaning continuous administration of this drug will inhibit TSH, inhibit LH, leading to inhibition of testosterone production. Okay, continuous also means long-term usage. Okay. And that's pretty much it for Endoform.